All right, good afternoon. Just going to give it a couple moments for everyone to join us. Hope everyone's having an excellent Friday afternoon. I'm going to go ahead and get us started here. So welcome to our system-wide Grand Rounds, Baptist Health and Wilson Children's Hospital. We thank you for joining us. I'm Dr. Francesca Varallo-Sims, Director of Education and Training for Baptist and Wilson Children's Behavioral Health. Please help me welcome our speaker today, Dr. Kroom. Dr. Christopher Kroom is a professor of surgery at Mayo Clinic, Florida, practicing both transplant and hepatobiliary surgery. He completed his surgical residency at University of Western Ontario in Canada. He took time during his residency and completed a graduate degree in epidemiology and statistics from Harvard University, as well as a research fellowship through Beth Israel Deaconess Medical Center in Boston. He subsequently completed an abdominal transplant fellowship at the University of Western Ontario, followed by a fellowship in hepatobiliary surgery from Mayo Clinic in Rochester, Minnesota. He is currently an associate editor for the journal Liver Transplantation. His research interests include donation after circulatory death, liver transplantation, in situ and ex situ machine perfusion, donor liver steatosis, liver regeneration, and hepatobiliary oncology. He has over 130 peer-reviewed publications in transplant and HPB surgery. Welcome, Dr. Kroom.
Thank you very much for having me here today. I'm really excited to talk to everyone on a topic that's very important to me. And I think really, the title says it. I think we have a national organ shortage. I'm going to talk about that. And I truly believe that donation after circulatory death donors have the potential to address that. So what is the reality? Well, 21 patients will die each day waiting for a transplant. There's over 100,000 people on transplant lists in the United States. And a patient will be added to the waiting list every 10 minutes or 6 per hour, 144 per day, or 52,000 per year. And these are not just statistics. These are people. These are your friends, your neighbors, people on dialysis, people in liver failure, children. These are not all adults. And of course, unfortunately, if these patients don't get an organ in a timely fashion, you have families and they may no longer be with us and no longer make it. But I'm here to talk about some of the good stories too. So I get to see these stories where patients that were very sick or on their deathbeds get a new grant of life or new lease of life through a generous gift that someone has given them. And so these are some pictures of some patients that I've seen that have agreed to let me show their pictures. So when we look at deceased donors, there's really two types of donors that these can be classified as. The first is the brain dead donor. That's sort of been the most common donor since about 1968 when brain death was recognized in the United States, and historically has made up about 70% of donors. The other type of donor is a donor that has a terminal illness or a traumatic brain injury that is not compatible with life, and care is withdrawn, and they become a donation after circulatory death donor. Historically, that was about 30% of donors, but that's changing. As an example, in 2024, about 65% of the livers we've transplanted here at Mayo Clinic, Florida, have been from DCD donors. So I think there is a huge unrealized potential that's always been there, and we're just starting to really explore that. And then, of course, living donors. With living donors, obviously those provide an excellent source of organs as well. But many people have donor family members that also have morbidities, and not all people that want to be donors are candidates, and not all people have a donor. So donation in the United States is really governed by the dead donor rule. And so what that rule says is that you cannot cause a donor's death by removing the organ. So that makes sense. Obviously, nobody would want to do that. Donors must be declared consistent with medical and legal standards. So that's sort of the guidance as to who is a deceased donor. And with that, there's two established criteria for recognizing death in the United States. The first is irreversible cessation of whole brain function, or brain death. And the other is irreversible or permanent cessation of circulatory function. And that's where those DCD donors come in. So with a DCD donor, most of the DCD donors in the United States are what we call controlled DCD donors. So these are not people that are rest in the field generally, and where CPR is initiated, et cetera. It's someone who's made it to the hospital. The withdrawal of care is usually planned and done in a planned fashion. And they are declared deceased once they've had cessation of circulatory function. After that takes place, most hospitals have a no-touch or a wait time of between 2 and 5 minutes to ensure that there's no auto resuscitation. And then at that point in time, you can move forward with organ donation. So with a brain dead donor, these are all the organs that could be procured from one donor. With DCD donors, it's pretty much the same, with the exception of bowel transplant. It's pretty rare to use a bowel transplant from a DCD donor. So with the DCD organ donation process, the decision to withdraw has been made because the patient has a non-recoverable condition. At that point in time, the family could be approached about the possibility of organ donation. So the decision to withdraw care should have already been made. And if the donation is consistent with both the donor's wishes and with the family's wishes, then organ donation can be pursued. Consent for organ donation is obtained if it wasn't done before when the person was alive, and then suitability of organs for donation is assessed. Most hospitals now have implemented this, which is a great way to sort of show respect for the transplant process and for the person who has chosen to make a very generous gift to somebody else. They have an honor walk where many of the healthcare professionals will stand and sort of pay respect to the person as they are transferred to the operating room for the planned withdrawal of care or for organ donation. In the ideal scenario for the DCD process, the patient is brought to the operating room, and I'll kind of talk about why this is important. The patient is prepped and draped so that they are ready to go forward with the donation process. And then at that point in time, the transplant team would leave the operating room, and they should not be involved while the withdrawal of care is taking place. That should be done by the primary care team. During that time, in many hospitals, the family is allowed to enter the OR. Usually the hospitals try to make it as sort of a positive an experience, or I guess, not a negative experience for the family. And they're allowed to be at the bedside, often hold the donor's hand, et cetera, while withdrawal of care takes place. Once the patient goes into a pulseless electrical activity, the family is escorted out of the OR. The surgical team is allowed to re-enter, and then that no-touch period of 2 to 5 minutes ensues, where no one is able to do anything to the patient during that time. At that point, there's a final confirmation of death, that there is no pulse, and then we would move forward with the donation process. As you can imagine, especially with the DCD donor, there is no blood flow to these organs, no oxygenation, and so these organs are basically dying in the process. Therefore, we do a rapid recovery, and we have to move very quickly to either restore blood flow to these organs or to remove them from the body and get them on ice as quickly as possible. So there's some differences, therefore, between brain death and DCD donors. Brain dead donors come to the operating room. They have already been declared deceased. Usually the death certificate has already been filled out. And then the procurement process takes place in a little bit more controlled of a fashion, because we're able to make incision and do the procurement process while the heart is still beating because the patient is declared brain dead. Obviously, that is not the case in the DCD process because they still have not passed when they come to the operating room. And so you have, unlike with the brain dead process, this warm ischemic time, or time when those organs are warm, not getting oxygen, not getting blood flow. And so they are very quickly deteriorating the longer that time is. To stress that, I think we like to say, every minute counts following withdrawal of life support. And so we would really favor, and I think most transplant institutions would withdraw in the operating room for that reason. I think there's a few things. Number one, it usually leads to a shorter warm ischemic time because things are able to happen more quickly. Higher likelihood of successful donation. So I think at the end of the day, we all need to keep in mind the donor or the donor's family's wishes were for them to be a donor. They want them to be a donor. They have accepted at this point that regardless of how things go, the person is not going to survive, and therefore it's sort of a double letdown when they find out they're not going to be a donor for whatever reason. And then in the operating, it's much more controlled as well. There's a little bit less chaos, a little bit less rushing. If withdrawal takes place in the ICU or the PACU, there's a little bit longer time because you have to rush them from there after they've been declared deceased. Statistically, there is a lower likelihood of successful donation, and it's much more hectic. So looking at that warm ischemic time, that's sort of the total time from withdrawal of life support until either flush of the organ and placing it on ice or reperfusion through NRP, which I'll talk about shortly. But really the time when there's the most damage to those organs is when there's little or no blood pressure, no oxygenation, and basically those organs are suffering during that time. I think it's important, and most protocols have this for DCD donation, to have an arterial line in place that allows accurate assessment of the patient's blood pressure so that the withdrawing team really can have a good idea as to when that patient has passed or when they have gone into circulatory arrest and no longer have a perfusable blood pressure. Again, keeping in mind that every minute counts, pulseless electrical activity is an acceptable criterion for declaration of circulatory arrest. That holds true both for donors and just for general patients. What we often see is that you might have electrical activity in the heart for quite some time, even after the patient has passed. There is no organized rhythm or contraction of the heart, but yet you will still get some electrical activity from those cardiac cells. And again, as soon as the patient is in PA, there is no perfusion of the organs, and those organs are essentially dying. So what is PEA? PEA, of course, is pulseless electrical activity. It's a clinical condition defined by electromechanical dissociation, or when you could have electrical activity but have no actual organized cardiac contractility. Patients usually have no palpable pulse when their pulsatile pressure is somewhere between 2 and 14 millimeters of mercury. Again, that's to say, a pulse pressure of 8 on 7 is consistent with PEA, and really there is no pulsatile pressure if you check the pulse on that person if they have a pulse pressure less than 10 or so. So this is just showing a case where a patient probably is in pulseless electrical activity. Again, you have a blood pressure of 10 on 7. At that point in time, usually the team would check manually or through auscultation to see if indeed there is any pulse. And then if there is not, they can be declared at that time. So why are we so worried about that? Why is time so important? This was a study looking at time from asystole, or when the patient went into PA, until cross clamp of the organ. And what it found was that for every additional minute of asystole to cross clamp, there was about a 16% increase of odds of developing ischemic cholangiopathy, which is a bad condition where you get death of the bile ducts in the liver and often leads to graft failure and retransplantation. So even minutes sometimes can have a significant impact. So when we're talking about liver, this ischemic cholangiopathy really is one of the main issues we've struggled with DCD transplantation, and why until recently people didn't use as many of these DCD livers. This is a picture showing a biliary tree. You can see that you have numerous sort of abscesses or lakes of bile and most of the bile ducts have died at this point in time. These patients get very jaundiced, and really, when you have massive injury to the bile ducts like this, stents and things really don't help, and these patients often require retransplantation. So if we look historically at DCD liver transplant, what we can see is those patients that got a DCD liver, the top line in blue, are those that did not develop ischemic cholangiopathy and they had excellent survival, probably 80% or more at 5 years, whereas those that did get a transplant with ischemic cholangiopathy had significantly reduced survival down to about 35% at 5 years. So preventing that really is the crux to us being able to use more of these DCD livers. So what are the current pressures in the US? I think, I talked about earlier how there's a lot of people on the liver transplant and other organ transplant waiting lists. People die every day. And so I think that the federal government has really looked at that and said, what can we do to improve that situation and really be a world leader in terms of organ donation, which we've done a really good job of so far. So there was an executive order in 2020, and it basically updated how donation rates are assessed for OPOs. So organ procurement organizations, or OPOs, are the ones that run organ donation in each of the regions of the United States. You can see here we have a map showing all the different OPOs. It looks like a puzzle. And as you can see, some of them are state-based, but many are not. I think we have 4 or 5 in Florida alone. So it sort of just depends on the region of how many OPOs there are. But what they did with those orders was put more pressure on the OPOs to really perform in terms of approaching patients and converting eligible donors or people who could have been donors into actual donors. And it also, there was some OPOs that really had very low donation rates. And so there was pressure for those poor performing OPOs to increase donation rates and get up to where some of the better OPOs were in the country. And ensure of donors that are come to the OR or are potential donors, that those organs are maximally utilized to help people on the transplant waiting list. So if you look at organ donation, it has been going up in the United States. So I think everybody should be congratulated on doing a good job. I think we recently passed Spain as having the highest organ donation rate per million in the world. So I think that's really a testament to our system and most of all to the donors themselves who have agreed to be donors. But if you look at the donation rates or the types of donors, you can see, well, there has been an increase in brain death donors. Really, the dramatic increase has been in DCD donors. And I think it just has to do with the large number of potential donors out there who have non-survivable injuries yet don't meet the criteria for brain death. And if you look at 2024, I don't have the numbers, but it's gone up even substantially more in the last year. So when you looked at the United States compared to other countries in the world, and this is data before 2020, what you can see is of the donors that went to the OR, the number of livers that were utilized was only 27% of DCD donors. And that had largely to do with what I mentioned earlier about concerns for that ischemic cholangiopathy. Now, when you looked at many of the European countries, their rates of utilization were much higher. Belgium was 75%, and most of the other countries were well over 50%. So what was the big difference? The big difference was they were using something called NRP, and I'm going to talk about that in a minute. That's called normothermic regional perfusion, as well as other forms of machine perfusion. And basically, the general concept is taking these organs that have suffered ischemic injury and recovering them so that they're able to perform better and have a lower chance of having primary non-function or not working in the recipient. And so all of these European countries really were employing these technologies before they were being employed in the United States. So how do we improve utilization for organs? I think clearly it is through machine perfusion. Some of you may have seen these either in your hospitals or on TV or other forms of news. We now have ways to both keep organs pumping outside of the body. You can see some of these machines up here, which provide blood flow, oxygen, etc., to the organs. We can look at making bile, etc., and allow recovery of those organs before they are transplanted into an individual. And then as well, NRP, where we do provide some oxygenation and flow to those livers while they are in situ or still inside the donor before they are taken out of the body. So what are the main different types of machine perfusion? I'd break it down probably this way. So there's both ex situ, so outside of the body, and in situ, or inside of the body. So with ex situ, the first is normothermic machine perfusion. So that is where the organ is perfused outside of the body. It is perfused with blood. It is a usually physiologic temperature, fairly close to that. And you can see the organs working, etc., because they usually have a temperature somewhere between 35 and 37 degrees. There are 2 platforms that are FDA approved for that and are in clinical use. The other way is through hypothermic machine perfusion. So that is where the organ is kept cold and is perfused with a cold oxygenated solution. That allows it also to recover. And I think the jury is still out on which of these is sort of the better of the 2 technologies. I think they all have their own advantages. The third way is in situ perfusion. So that's where I said normothermic regional perfusion, or NRP. And that's where we isolate the organs in the body right before they come out. And they are, for a short period of time, perfused with oxygenated blood to allow them to recover before they are taken out of the body and placed on ice. So when we look at NRP, it really has increased organ utilization. This was a study looking at different organs, and it was showing that compared to the old way, where basically we just did a rapid recovery with ice, there is a 3 times increased likelihood of the liver being transplanted if it's recovered with NRP compared to just static cold storage. With kidneys, there's about a 1.5 time chance of it being used, and with pancreata, about a 1.6% chance. So pretty substantial numbers, really higher utilization rates, and within a large number of people waiting for organs, I think that's something we really need to take seriously. So when we talk about that normothermic regional perfusion, there's really 2 types of it. So one is called TA-NRP, or thoracoabdominal NRP, and the other is abdominal NRP. And these don't really refer to which organs are being transplanted. It refers to which part of the body is getting in situ perfusion. So with TA-NRP, once the patient is declared deceased, the team would go in, cannulate in the chest, in the aortic arch and right atrium. The vessels to the head and to the arms are clamped so that there's no blood flow or chance of reanimation to the brain, etc. And then both the thoracic and abdominal organs can be perfused. This technique can be used for heart DCD recovery, so taking hearts from DCD donors, which was something that was never done before. And in many of these cases, the heart is restarted temporarily before it is procured to make sure that it is pumping well, etc. An alternative is ANRP, or abdominal NRP. In that setting, the aorta and vena cava are cannulated, and just the abdominal organs, so the liver, kidneys, pancreas, are perfused in situ. There's no perfusion anywhere else in the body, no perfusion to the heart. The heart is not restarted. So this is a picture showing NRP from the abdominal standpoint that we did. You can see we have the cannulae in the aorta, cannula in the vena cava. And then we have the yellow thing here is a coda balloon, which is inflated in the supraciliac position or right before the chest so that there is no blood flow anywhere else, just to the organs being recovered. This is showing again the key with abdominal perfusion, that this balloon is inflated. Usually we have a clamp as well. And so you only get perfusion to this part of the body. It's isolated there, hence the name regional perfusion, in that it's not perfusion to the whole body. So how does this technique really work? So when you look at a brain dead donor, I've sort of simplified things here, but this is your ATP or energy stores for the organ, and you're at a normal level because it's a brain dead donor. The heart is still beating. That organ is cold flushed, and while the organs are cold, it does decrease the metabolic rate, but there is still some energy consumption. And so over time, that decreases slowly. As long as you get the organ transplanted quickly enough, you don't sort of reach irreversible stage of cell death, and you're able to have a good outcome with that organ. With a DCD organ, in the usual setting, you've already had that warm ischemic period where there has been no oxygen or limited oxygen, limited blood flow. And so you're already in a pretty big deficit in terms of cell energy stores. And so pretty quickly, with even just a little bit of cold time, you can cross that threshold of cell death where no matter what you do after that point, that organ is not going to recover fully. With NRP, you again are still going to have that period where you have warm ischemic time during the withdrawal of care until the patient passes. But now immediately you're going to provide some in situ perfusion and oxygenation to those organs, bring them back up to a relatively normal level in terms of energy stores, et cetera. And then when you cold flush it, you're sort of starting in a much better spot, and are able to get that organ transplanted before you reach a process of irreversible cellular injury. This is a video just showing a donor on abdominal NRP. So you can see here the bowel looks pink because it is getting blood flow. The liver looks pink, and you can see the chest is open there. There is no heart beating, no blood flow to the chest, etc. This is another case where the heart and lungs had been procured. So this person is on abdominal NRP. You can see again the liver looks nice and pink, and yet there is no heart and no lungs in the chest. So it is truly just perfusion of just the abdominal organs. This was looking at our initial experience doing NRP donors. I think this was a few weeks ago, but we had done 104 cases at that time. The median amount of time that we were running on NRP or running on that circuit was 67 minutes. And we had a liver utilization rate of 76%. So if you remember that slide I showed before, saying that in the US, the liver utilization rate was about 25% with static cold storage. So this is a pretty substantial increase where most of these cases, the liver is getting used. And in more of the cases, the kidneys are getting used as well. So how do these organs do? We looked at this. This was our first 83 cases. And what you can see is we had much better outcomes than we did with static cold storage. I think most importantly, that ischemic cholangiopathy that I talked about, or where you have that bile duct death, no cases out of the 83 compared to a usual of about 11.5% in our previous 297 that we had done with static cold. Patient survival 98.4%, and graft survival 96.7%. So really very outstanding outcomes. And I think this has allowed us to pursue many more DCD donors, both in terms of age and other factors that we wouldn't have before. You know, I think most programs would have had an age cutoff for DCD donors of about 65 years before. We have no age cutoff now. I know we've used a few 73-year-olds, and really we don't worry that much about age. If it's a liver that looks good, that's functioning well, then we're happy to move forward with it. So the next topic I was just going to talk a little bit about is the concept of donor care units. Um, Donor care units, initially, I believe the first one was in St. Louis. And this was where a facility where instead of going to donor hospitals to do all of the donors, they actually brought the donors to a centralized location where they had all the facilities to perform donation. And then we're able to do that in a more efficient manner, and found that they were having higher organ utilization because of that. It also helped with OR availability, both for the donor hospitals as well as for the teams if they needed certain OR times, et cetera, in order to match with when their recipient would be ready. These are now, if you look in the United States, I think this was maybe a year or two ago, so there is more now, including one in Jacksonville. But these were cities that had donor care units at the time that this map was drawn. So this is not something specific or coming directly from transplant centers. It is coming from the federal government. So the NASEM report was published and looking at ways to maximize organ donation and increase equity in the organ transplant system. And one of their recommendations was that all organ procurement organizations should have donor care units and should try to use those. Their wording was to better serve donor families and increase cost effectiveness and foster innovation in organ rehabilitation and donor intervention research. The HHS, or Human Health Services, should require each of the 57 OPOs to create, establish, and manage a donor care unit. And again, keeping in mind, ultimately the goal of organ donation is to honor the wishes of the donor and the donor's family, and to maximize the potential gifts of life. So this was coming directly from the federal government as an initiative to increase organ donation, and one of the things they've been trying to do to decrease the number of people on the waiting list. So what are some of the benefits to this model, or having centralization of donor care? When you looked at statistically, there was a higher overall organ utilization rate, about 3.43% compared, or sorry, 3.43 organs versus 2.69 organs per donor. It doesn't sound like a lot, but that's at least one extra organ per donor that is being utilized. More expeditious organ recovery due to having dedicated operative suites. So, we've all struggled where it's hard to get an OR time. We all know OR time is precious. Maybe in your hospital, your team has their lists, their patients that are waiting to have their surgeries, and they're getting bumped by an organ donation, and they're frustrated because of that, or vice versa. So I think by having dedicated OR time for this, it certainly allows everybody to be more efficient and go on with their days. Minimizes hospital bed shortages. Again, we're all dealing with this. By having dedicated beds for this specifically, you don't have someone sitting in an ICU, taking up an ICU bed for multiple days while they're waiting to be a donor or waiting for an OR availability. Alleviates the extended use of hospital staff. We've seen that too, where in order to do a DCD donor, usually you need to have an ICU staff or something like that come down to the operating room. Sometimes they're tied up for an hour or two, and they've got their own patients to deal with. And so taking that burden away can also be valuable. And that's kind of what I said there. It relieves ICU and ER staff responsibilities of having to come and manage these donors, et cetera. So what are some of the other benefits? I think standardizing the methodology of organ perfusion to ensure safety and reproducibility is particularly relevant to advanced perfusion such as NRP. So organ donation has become more complicated. Those machines that I mentioned, both NRP and ex situ perfusion, they're great. They have increased utilization. They have increased quality and outcomes for organs. But they're more technically challenging, and they require teams that are trained in doing it. They require more staff to do them. Usually we need a perfusionist with us. And so by not having to bring those staff and equipment to multiple different hospitals and having them more centralized certainly allows for more efficiency and more cost effectiveness. Reducing variability in the assessment of whether or not organs are suitable for transplantation. Again, having pathologists that are frequently looking at transplant slides, having ICU care of people that are, again, familiar with the organ donation process, can have less variability. I think this is a really important one, but we talked about sort of the withdrawal process earlier on in this talk, about how PA is recognized, where the withdrawal takes place. And what we see as we go to many different hospitals, every hospital has their own policy, every hospital has their own procedures. Some of those are more efficient than others. Sometimes you go to a hospital that they've done one DCD donor in the last year, and so they're not completely comfortable with it. And so I think having it done in a more centralized place where that is not a problem, and the people are doing large volumes of these, is able to keep things based on protocols. There's less subjectivity, and people who are very familiar with the DCD process. So as I mentioned a few slides ago, there is a DCU now located in Jacksonville. It is housed in the Mayo campus, but it is not a Mayo DCU. It is run by the OPO itself. In 2023, there were 22 donors in the surrounding area that were transferred to the DCU for organ recovery. I think a decent number of these were from Baptist, but some were from other hospitals as well. In 2023, all of these were brain dead donors, and there was a total of 54 organs that were recovered from those 22 donors. In 2024, and I only have data through September, but there was 22 donors in that time period, so a shorter time period. 8 brain dead donors and 14 DCD donors, which is really a remarkable number, were transferred. 3 of those DCD donors were from the Baptist Health System. I know that. I checked that statistic earlier today. Number of organs used was 53 from those 22 donors, and transfers originated from 7 different hospitals outside of the DCU. So not 7 hospital systems, but 7 total hospitals. So it's continuing to grow, and I think again the process is becoming more and more streamlined, and is consistent with what the Nason report and the federal government had recommended. So this is a poem. I'll read it just kind of in the end. I think, again, it's important always to come back to why are we all doing this? Number one, I think the donors, this is the wishes of the donor family. So this is a poem that was anonymous author, but it's now time for me to move on into the dusk, but also the dawn. I will remain as the morning comes, as I've left behind a gift for someone. So another may walk, may talk, may see, where life was locked, I offered a key. I'm a donor to someone in need, my final gift, my final need. So what is the summary of my slides here? I think people die every day in the United States due to the shortage of available organs. As I said, there's over 100,000 people on the transplant waiting list. DCD organ donation has a large unrealized potential. I think we're seeing that. I think those numbers are growing, and I think they're going to continue to grow much more than the potential for brain dead donors. I think we were always pretty good at brain dead donors. I think, at least compared to European countries, we were quite a bit behind with regards to DCD donors, and I think we're finally starting to sort of realize that untapped potential. DCD protocols should be developed to increase the chances of fulfilling the donor's wishes to be a donor. So I think, again, making protocols that look into all those things I've mentioned and sort of maximize the chance of that being effective. Trying to do the withdrawal in the OR, making sure there's a policy around PEA, other new technologies and sort of how those are going to play into it, et cetera. at least we've definitely seen this, and I know other OPOs have, normothermic regional perfusion, or NRP, is drastically increasing the likelihood of organs being placed from donors. And we've seen really significant improvement in outcomes. So we've been very pleased with how that's been going, and I think we're going to continue to build on that. And finally, transfer to donor care units has been recommended by NASM to better serve donors and donor families, increase organ utilization, increase cost effectiveness, and foster innovation, organ rehabilitation, and donor intervention research. And I think in particular, when we're talking about these new technologies, machine perfusion, et cetera, that's where we've really seen a benefit of things being centralized, not bringing equipment, having standardized protocols, et cetera, really has seen positive impact. So I guess I'm finished a little bit early. I can talk a little bit more about a few other things, but I'm hopeful there'll be some questions, and I can certainly elaborate more on those from the audience. I'm happy to answer anything, whether it be sort of basic concepts of organ donation down to more detailed questions, et cetera. So thank you.
Thank you so much, Dr. Kroom. Absolutely, yeah. So at this time, if anyone has a question, they can pop it into the chat or in the Q&A, either way. And while we're awaiting a few questions, I'd like to just ask one. So I know you are quite prolific in terms of your, research and such. And so are you involved in any active research projects currently with Mayo?
Yeah. So, I mean, a few things we're looking at. I think one of the big questions that's come up, as I said, these machines have allowed us to go after donors we would never have gone after. We would never have taken a DCD liver from a 70-year-old in the past because the outcomes just weren't good. Also, donors with longer warm ischemic times, maybe it took an hour and a half, maybe even 2 hours for them to pass away. We would never have looked at that before. Now we are usually putting those on one of the pumps, but then the question becomes, how do you know that it's good? How do you know that it's going to work well in your recipient? Because nobody wants to transplant an organ and have a bad outcome in the recipient. So that is really what we're looking at. Is there better markers that we can use to assess how good this liver is going to be or this kidney is going to be while it is on pump? So we look at things like lactate. Livers clear lactate. Usually when they're healthy, they're clearing that. So that's one of the things we looked at. We've got a few projects ongoing where we are looking at other biomarkers in terms of how well these organs are going to do. We've used indocyanine green, which is taken up by the liver and then excreted by the bile ducts, and looked at the clearance of that to see if that gives us a window into the health of the bile ducts. Because as I mentioned, that bile duct injury is sort of one of the really key limiters that has prevented us from taking more, I don't know if the word marginal is correct, but kind of historically higher risk livers, because we're worried about those bile ducts. So we're trying to see, is there a better way when we can tell this liver is going to be good or not? I mean, what we really need is like a green light or a red light. Green light means it's going to work well. Red means don't use it. So that's of course oversimplifying it, but I think that has allowed many cases where the liver wouldn't have been used just because of risk, to maybe minimize that risk and say, yeah, you know what, despite some of the riskier factors on paper, we can see this liver's working great, and it's gonna be do well the recipient. So I think that's one of the main things of research we've looked at, because we are probably doing one of the larger numbers of pumped organs in the country. So.
Any other, big things on the horizon in terms of, you might not be working on it currently, but in the future?
Yeah, I mean, I think the question lots of people ask is like xenotransplant. So I mean, I think there's so many people waiting, especially for kidneys. I mean, there's a lot of those 100,000 people are on dialysis waiting for kidney transplant, and I think the federal government, I like to think they always have patient survival at the center of their argument, but we know finances are important too. And dialysis patients are very expensive. It's a very that is all paid through Medicare or Medicaid, so it's a big burden on the federal budget. And I think they are really looking at ways to how do we get these patients off dialysis and back into the workforce or whatever else that may be. So I think the one thing which we've really been doing well, and we're going to continue to do well, is increasing organ donation, like we've done, and increasing use of organs for people that want to be donors. But I think the other question that would really be a game changer is, would xenotransplant, or can we take kidneys from pigs that are genetically engineered and use those for transplant and have it almost like an orthopedic getting a new knee. You order your kidney and it comes in and you put it in. So I think that would be everybody's dream. Certainly we would have more transplants to do than we could possibly do. We need to hire a whole bunch of new people, but they're getting closer. What we all forget is, so even in, you get a kidney from another human, you still need immunosuppression, but genetically, even if that person looks nothing like you, et cetera, genetically, they're almost identical. I mean, it's so close. And yet we still need immunosuppression. So with pigs, there's some things that are very different. They had some proteins that immediately basically cause reaction and rejection. So they had to genetically engineer pigs so that they don't have that protein. So that was kind of one of the first steps, which they've done. And people may have seen on the news, but a few of those kidneys, they have transplanted into people that are brain dead. So people that have agreed to be sort of pioneers in that research, they transplanted those kidneys into those people and watched them for, a few weeks, et cetera. So I think that's exciting. I think it's getting further ahead, but I suspect you'll need at least 10 years of clinical trial before any of that will be mainstream, and they haven't even started a clinical trial. So I think we're looking, I get patients all the time that ask me, should I just wait for a pig kidney? But the answer is, realistically, I hope before I'm maybe halfway or a little over halfway through my career. I hope by the time before I'm done that we are doing pig kidneys, but I think it'll be closer to the end of my career as opposed to anytime soon. But
yeah, then you're definitely going to have more DCUs, when that
yeah,
starts, to your point.
Absolutely. The
So-
pigs are actually quite they're quite expensive because they're genetically engineered, and they have them because of especially post-COVID, the fears of zoonotic transmission and whatnot. They are like isolated from birth, basically in like a sterile environment, so that they don't get zoonotic viruses and things like that. So.
Well, we need to talk just on this.
Yes, absolutely.
The pig kidney discussion. Yes. Wow. Well, thank you so much, Dr. Kroom. Just a few notes for our attendees before we conclude. I've popped into the chat the link to the post-event evaluation in order for you to obtain CME or CE credit. If you're wondering what disciplines specifically are going to grant that, please reference the advertisement flyer, but absolutely physicians and nurses will qualify for credit. Our process for approvals take a little bit longer depending on what discipline you are seeking them for. So please just be patient with us. Give us a couple weeks to get those processed, and they will be directly input into CE Broker. Again, thank you so much, Dr. Kroom, for your time. It's been a pleasure. I hope everyone has a wonderful rest of the week and a happy weekend. Thanksgiving too. Okay.
Thank you very much for having me.
All right. Have a good afternoon. Bye-bye.